M&M time. We're going to talk about an Amulet embolization case that happened at the end of May. Really educational case. I think there's a lot to learn from. Let's begin. What we'll do today is we'll talk about the case itself and then review this specific left atrial appendage occluding device, and then talk about the complications thereof of this particular device itself, and then some complications that can relate from transeptal punctures, and then what are our options if we do encounter right to left interatrial shunting, which is one of the complications that we saw out of many of the case. So to introduce the case, we had an 82-year-old male. He was supposedly functionally pretty active. He did have some pathologies that he was suffering from, which include paroxysmal AFib. He was on Plavix and aspirin for that, and he, at the beginning of the year, had a subdural hematoma on aspirin, and so it was thought that in order to decrease his bleeding risk, that a left atrial occlusion device would be the best option for him. Unfortunately, this device embolized and had a traumatic type A dissection, and the actual Amulet device embolized into the descending aorta. It was then determined that not only retrieval of the device was a goal, but also a type A replacement was indicated surgically. These are a couple photos from his imaging that was done upon his arrival. Patient arrived to us intubated, unable to obtain a neurological exam, and hemodynamically stable at the time. And you can see on the left side of the screen, that's the Amulet device in the descending aorta. You have dissection flaps seen in the ascending arch and descending in these other photos on the right. You can see that's in the arch. And then this is the Amulet device that is seen in the descending aorta on echo. Course of events, this was a very long case, but I'll stick to the salient points and then get into a discussion. We got into the room about 4 o'clock p.m. I was on call that day, and we noted a severe left pleural effusion. Contained rupture was evident on imaging, and then we began to proceed with deep hypothermic circulatory arrest. The plan was to remove primarily the device from the descending aorta under circ arrest, and then proceed with a total arch with a Thoraflex graft. And then the idea was that they would deploy an endovascular, it's actually not a TVAR, it's a Gore-Tex-C stent across the actual defect. And I have a picture to show this, but very unconventional repair because you have to excise a foreign body out of the descending. And so that was the initial surgical plan, was get the device out of the descending aorta, replace the ascending in the arch, perform a Thoraflex graft. Cardiopulmonary bypass totaled 5.5 hours. Circulatory arrest was 55 minutes with integrated cerebral perfusion. This was the device I took a photo of after it was primarily removed under circulatory arrest. As you can see, the device is still in its native form. It didn't bend or twist, as it's very stiff in nature. Once we weaned from cardiopulmonary bypass, there was significant right to left shunting with hypoxia. This was noted whenever our SVR dropped, or mean systemic pressure dropped. And so we noted right to left shunting that was perfusion dependent. We started nitric oxide in an attempt to reduce RV afterload so that the right to left shunting would be less prominent, even though we had preserved RV function. I had a discussion with Dr. Orozco, and due to the nature of time under cardiopulmonary bypass, clamp time, myocardial protection, and we knew we were going to encounter profound coagulopathy from the patient being on Plavix and aspirin, the decision was to medically manage this, and I think that this was the best option for the patient, because if we went and had another pump run, opened up the heart again, and repaired the ASD primarily, I don't think the patient would have ultimately been able to get out of the operating room from coagulopathy. After the total arch Thoraflex was done, they then deployed a hybrid Gore-Tex thoracic stent in order to sort of cover up the primary defect in the descending aorta. I have a picture to show this. This is also unconventional. This was moderately successful, as usually fluoroscopy is required to appropriately place these. We were doing it under epi-aortic and TEE guidance. Dropped the patient off at 5 o'clock, so the case totaled about 13 hours in the OR. So total what we did, reconstruction of the non-coronary sinus, is the dissection flap was going into the root. Primary repair of the descending, chest was left open. He had a TVAR with Relay Pro and then a Gore C-tag, which is a thoracic stent with a Thoraflex, and then the left hemiclamshell. So lots of bleeding. We had profound coagulopathy. We gave autologous blood back, packed reds, 4 cryo, 4 platelet, 6 Kcentra. So this is what it somewhat looked like. You have the Thoraflex graft that was here. There was an island in place, and then they repaired all the way down to the root, but they didn't, they had the non-coronary sinus, but they didn't actually have to intervene on the aortic valve itself. But after the Thoraflex was placed, they went up with a thoracic stent, because if you imagine that the foreign body was somewhere above the renal or the celiac artery, so you had to cover, in case that there was a leak, you had to cover this in a hybridized fashion. You couldn't just leave the Thoraflex here in the event that there was some compromise to the actual repair to the descending aorta from removing that. And so unconventional repair, but I think this was the best surgical option given the cards that we were dealt. You can see here, this is the Gore-Tex stent. So this was deployed. They already had access in the femoral artery from the procedure. And so they tried to initially snare the device out, but were unable to snare it. And so they deployed this Gore-Tex with TEE and epi-aortic imaging. Post-operative day 0, patient was dropped off at about 5 a.m. He had ongoing coagulopathy. I want to say that there was 3 to 4 dozen blood products given in addition to what we gave within the first 12 hours. They encountered profound vasoplasia, and the neurological exam was very non-reassuring. And so they imaged the brain and found age indeterminate infarcts. Unsure if when these actually occurred. We would have needed MRI, but these were some of our imaging modalities we used. You can see there's infarcts in multiple different territories. This is just designed to be a brief review of left atrial occlusion devices. So this has been going on a little over 2 decades. The first device was a Plato device. A little over 200 patients received this, and they started to see somewhat of a risk reduction in stroke, but this was withdrawn about 5 years later. And I'm not sure why it was withdrawn, but nonetheless it was. And then in 2015, we now have the device most commonly known as the Watchman. It's now undergone its 2nd generation. It has lower directed related thrombus, safer implantation, higher seal rates. In Europe, they've been performing this for about 6 years longer than the United States, but it gained FDA approval in 2015. So this is the actual device. Pretty remarkable engineering, but it's a 2-phase occluder, so you have the distal neck that goes inside of the left atrial appendage ostia, and then the large outer covering is designed outside of the left atrium. So this is self-expanding, and I have a video to show this. In addition, it's made of nitinol, so there's nickel and titanium, and then this mesh that's around to facilitate endothelialization. And it comes in a myriad of different sizes to facilitate placement in nearly all ranges of adult population habitus. So this is a comparison just between Watchman. There's another device called the LA Lambre, or I'm not sure how to pronounce that. But the thing I want to mention is the delivery system itself in the outer diameter of the sheath. So usually this comes in two different sizes, 14 and 16. The 14 is for the smaller ranges of sizes, and the 16 is for the outer. 14 French is the outer diameter of the Watchman. And so how it sits is it's supposed to sit right inside the neck of the left atrial appendage, and you have a sealed at the orifice. And then there's two components that are important with this device, and they're both related to a phenomenon that the interventional cardiologist will discuss called compression. So if you have compression of this neck that's low, meaning the actual contact and the ability for this to sit, if the compression is low, the embolization risk is high. And if the compression is too high within the neck of this, then there's risk of eroding into the actual surrounding structures. So problems that can occur around the left atrial appendage, the circ is right near the mitral annulus, you have the aorta mitral curtain, you have adjacent structures near the aorta. It is not a benign real estate, and so you have to have a careful balance between low and high compression. And unfortunately, embolization is higher in the Amulet population, and we're going to talk about that. But first, I want to show you the device itself.
So where did you stop? We had the data, and all the data we had to wait a year to start.
So you can see the self-expanding nature of this actual device itself through this outer sheath. I'm not sure if this is 14 or 16 French, but this is a very large sheath. You can see there's penetrating, they look like hooks or wires that allow for anchoring stability.
The material in here, is this to help with endothelialization?
Yeah, it's polyester.
Okay.
Polyester mesh.
So you can see that this is actually goes inside the patient, and then there's a smaller disc. The apparatus contracts, if you will, and then the outer sheath, this will blow up like a ring.
And this area is here to catch the ridge.
And yeah, he's talking about the ridge. So this sits outside of the left atrial ostia.
Yes. And so basically it's to seal the appendage versus plugging the appendage.
And this helps anchor the back end a little bit. And you got a small.
So you can see that the gentleman's fingers can represent compression of the neck of the left atrial appendage. So if he compresses this too small, there could be erosion, especially considering these wires are going to potentially penetrate and potentially compress and erode the structure. But if it's not compressed enough, you could have an embolization risk, which happened in this patient. Moving forward. So the location of interatrial septums, this is for most left atrial occlusion devices, and in green represents an inferior posterior, cross in the septum, and this is where we saw the patient developed an iatrogenic ASD, and so you would want to go posterior and inferior just to review some anatomy for the echocardiographers in the room. So, number one complication from the Amulet device is pericardial effusion. This is actually most common. In red, we encountered both dislodgement and embolization of the device, right to left shunting, and iatrogenic ASD. The other complications that I think, just for completeness sake, we go over is you can have incomplete closure, blood clot formation, air embolism, and also the left atrial appendage can function as an endocrine component. So you can have peptides that are released that may influence kind of the stretching of the left atrium and may regulate some water retention, especially these patients often have some component of systolic, diastolic, or combined heart failure. I found this interesting this is a proposed algorithm that was documented in Circulation, which is one of the interventional cardiology algorithms for iatrogenic ASD. Now, in this particular situation, we are not in a hybridized room. So this is assuming you're under fluoroscopy and, determine when to close it, when to not. About, I don't know the exact percentage, but it talks in one of the guidelines for the Amulet device that within 6 months, most of these ASDs endothelialize and close on their own, or they become not significant. If you're performing the procedure in a hybridized room and the patient has, profound oxygen desaturation, it's recommended that you just close the device percutaneously. However, if you don't, there's no clear guideline on what you should do, but there are certain factors you can look at with echo that will help determine what you should do and your justification for doing it. And there's 3 triads of what you're looking at. First, what is the patient's risk factors for actually, embolic phenomenon? Do they have pulmonary hypertension? Do they have a DVT, cryptogenic stroke, intracardiac leads? What you can calculate with the echo is what's the actual size. So you think if it's a 14 or 16 French device, 1 French equals 1/3 of a millimeter. So you're thinking most of the time you're around, 1/2 centimeter by 1/2 centimeter. And then your shunt grading and shunt direction will determine your QPQS. And you can also calculate, some component if you have TR with pulmonary pressures, PVR, although this is debatable if you can actually do this with echo, but you would, assess the RV function and then determine if you close it or not. And so this can help guide, but ultimately it comes down to a risk-benefit conversation with the intraoperative team and the proceduralist, and also the surgeon if it's involved that he needs to close it. That's all I have.